that I wanted to cover with you is a little bit more information about advance directives. I know that you got some information about it whenever you were in 111. And I know that you basically have learned a little bit more about it as you've gone through the nursing program. But I wanted to get a little bit more in detail with this, especially as we start dealing with patients that, especially in next semester, that may have situations where living wills and other advance directives would come into play. Basically, what are advance directives? They're legal documents that allow people to communicate their decisions about medical care to family, friends, health care professionals in the event they're unable to make those decisions for themselves. And that's a key point. In the event that they're unable to make those decisions themselves. Typically what you will see is that these advance directives, whether it be a living will or healthcare power of attorney, come into play when that person is not able to make their decisions. Basically, those two types, as we said, are the living will and healthcare power of attorney. What's the difference between those two documents? Both of them have to be done when they're of sound mind and body, so to speak. Living will does what?
Tells them what they want and don't want.
What they want and don't want.
And the power of attorney is who they make decisions when you can't.
Okay. Now, one of the things we'll see that's really different about these things is that what you find is that living wills came about pretty much in the 1990s. Basically, a lot of it was pushed by the Terry Schiavo case, the Quinlan case, where basically you had two fairly young people that suffered devastating medical events, and they were left in what is considered a vegetative state, meaning that they were able to sustain their heart rate, pulse, and blood pressure, but they had no upper brain function. Okay? And in both of those cases, family members petitioned to have them allowed to die of a natural death. Basically, in both of those cases, what they did is they withdrew food and fluids and allowed those people to die. Of course, there were a lot of controversy because it was husbands that were petitioning the court, and other family members were very, very opposed to that. So both of them went to the Supreme Court and upheld a person's right to make their decisions, or if those decisions were known. Now, the difference between those cases and a lot of other cases is that what they said were verbal designation of what their wishes were. They were not written down. So in 1990, the federal government came out with what we call the Patient Self-Determination Act, that basically told hospitals that received all federal funds, i.e. Medicare, or any types of financial assistance from the federal government, that they had to ask everybody that came into that hospital, even if you came in for a cold, or my uncle that had the slight cut on his hand, they asked him if he had a living will, and of course he's freaking out because he's thinking, you know, am I going to die from this 3-inch cut that I've got on my hand? But they required everyone to be surveyed to see if they had advance directives. And if they don't have advance directives, they have to provide the information for them to develop those. Over at Northeast, it's the chaplain service that does that. Because part of this law is that it can't be one of the healthcare providers that does this, okay? You can't witness, you can't develop. Yes, you can give them information, but they have to get it done by someone other than the healthcare team that's caring for them. All right, so what you will see, the living wills. What kind of medical care would or would not like to receive if they become able to speak for themselves? Basically, the most common types of things that are indicated are life-sustaining equipment like dialysis machines, ventilators, and also do not resuscitate orders. Instructions that not to use CPR if breathing or heartbeat stops. The other thing with the Terry Schiavo case that was added was artificial hydration and nutrition, i.e. tube feeding. You can withhold IV fluids and tube feeding if that is the person's wishes. Okay? You can withhold food and fluids if that is the person's wishes. And for the first time since the 1990s, you can designate if you want organ or tissue donation done in your living will. So what you're going to see that the medical health care power of attorney is a little different. This is the person that you designate in the advance directive to make your decisions if you're incapacitated. Now, it does not have to be your spouse. It can be someone else. It's whoever you name in that document. The only problem is that you cannot name your minor child as your healthcare power of attorney. It has to be someone non-minor. It can be someone totally unrelated to you. It can be your doctor if you want to do that. You don't want it to be your ex-wife that stands to inherit what you've got. You may hear it called durable power of attorney or healthcare proxy. Now, what people need to understand is that medical power of attorney is not like the regular power of attorney, okay? It's totally different. If I sign a medical power of attorney, this person has no legal rights over my money or finances, okay? That's different than a power of attorney that you might have to get for someone that is mentally incapacitated and doesn't have the capability of managing their own finances. Okay? Durable power of attorney or medical power of attorney only is over medical decisions. Okay? It may be not only end of life, but it can be in other medical situations as well. Say, for example, you're in a car accident and you're unconscious. That's not end of life, but that power of attorney person can go ahead and make decisions on whether to have surgery or what treatment needs to be done. Basically, document goes into effect when the doctor declared that that person is unable to make their own medical decisions. Now, one of the things that you will see when we talked about mental health is that you can design not only a living will, a healthcare power of attorney, but you can do a document for mental illness or mental disorders that would allow your power of attorney to make decisions for you in case you are incapacitated as well. Okay? When should they complete advance directives?
it's my feeling that everybody in this room should have one. Okay? It is one of those things that, you can't do it right before that car hits you. You want to make sure that everybody has an idea. Whether it's written or not, you need to discuss it with your family. Yes, Ashley?
That's the power of attorney, the medical power and the regular power. Say they disagree. The medical power of attorney wants to do this procedure, but the regular power of attorney doesn't want to pay for it. Is there one that's better than the other?
For health care decisions, the health care person trumps all, so to speak. Okay? One of the things that you should think about is if you have children. Whenever they reach the age of 18, they should have their own advance directives and their own power of attorney. Okay, one of the things that you will find is that if they do go to school and they are hospitalized by student health, you have no legal right to talk to student health about your own child unless you have that power of attorney. Okay, so that's one of the things that you should consider whenever you send kids off to college or with those family members. Where should they be stored? Well, put the originals in a safe but easily accessible place. That doesn't mean in the bank vault, because those are not easily accessible. Typically what you're going to see is that if you go to a lawyer, which you don't have to, they will make you about 5 or 6 copies so that you'll have one. Your power of attorney should keep a copy of your living will and power of attorney documents, signed and notarized, so that they've got them available. You probably need to take a copy of those to the hospital with you when you go, because they're going to ask you for them. And if they don't have them on file, which most hospitals will keep them on file, you need to make sure that those are kept updated in that hospital if you go in for subsequent events. Okay? Now, one of the things that's nice is that North Carolina allows us to file them with the state. And there is a state registry of advance directives and healthcare powers of attorney. So that if something does happen, if you're in the registry, it's voluntary, it's not mandatory. People can pull those documents up if they have been given the code to do so. It's not like Jason can go and look to see who's so-and-so's healthcare power of attorney unless Jason is working in that emergency room and has a specific code to come up with who that should be. One of the things you want to see is keep a wallet card so that you can have those. Usually tuck it behind your driver's license because that's where people will look for it. Now, I've given you the link. All of these documents are online. As I said, you do not have to have an attorney to do them for you. Basically, what you can do is to go to this website, download them. Okay, and you can see here they even allow you to do an organ and tissue donor card at this site. Basically, if you come up with the advance directives, let me just pull this up so that you can see. What some of the things that is a little different than it used to be. All right, a lot of general instructions here. Basically, you can initial when you want this to go into effect. If one is not initialed,
then it is not current and it is not applicable. One of the things that has been added is about suffering from advanced dementia or other condition that results in substantial loss of my cognitive ability. Because that's a major issue with the Alzheimer's patients that we've got nowadays. Okay? Basically, you see they may withhold life prolonging or shall withhold. Okay? May means that they have a little bit of leeway. Shall means they cannot change what your wishes are. Here you can say, I want to receive both artificial hydration and artificial nutrition, or only artificial hydration, or only artificial nutrition. Okay? So you can do one or the other or both. Okay? One of the things that we see a lot of times, though, with people that are dying, especially those in hospice situations, is you find that if IV fluids are given, it typically prolongs the death process for about 2 weeks. Typically without that fluid and food, the patient goes into a ketotic state, and the death is often less painful than it would be if those were added. The other thing that you'll see is that if you give them the hydration, often what you will see is that the lungs are much wetter, and it makes it more difficult for those patients to breathe. Okay? Basically, if you have a healthcare agent, this is your healthcare power of attorney. This is something that is different in the state of North Carolina. This advance directive will override instructions my healthcare agent gives about prolonging my life. In other words, you will follow my wishes, my document, and even though they're my healthcare power of attorney, they can't say anything different than's in this document. And that has only been added in the last 5 years because what they were finding is that some people were having a living will and they had a healthcare power of attorney, and the healthcare power of attorney said, well, no, we're going to do everything we can. And what happened is that medical team got into a very big ethical dilemma. Do I follow this person's wishes that are outlined in their living will, or do I follow the healthcare power of attorney? Well, unfortunately, what happened was that with that person incapacitated, we had to follow the wishes of the healthcare power of attorney, even though they may have been contrary to what the patient wanted. This is something North Carolina has added to make sure that, yeah, you're my healthcare power of attorney, but you can't do anything different than what I want, so to speak. Okay? Basically, one of the things that you need to remember is that it has to be witnessed. Again, most of the time, what the chaplain service will do is they will grab random people in the hall to try to find someone for witnesses. Because it has to be someone not related to the care, and it can't be a first-degree relative of that patient. In fact, it can't be even up to a third-degree relative of that patient. So it has to be someone, if you get it done in the notary office, it can just be a couple of people in the notary office. And that's one of the things that's nice about North Carolina. It does not require a lawyer. The forms are the same whether you go to a lawyer or not. Okay? It just has to be notarized in the presence of 2 witnesses. Healthcare power of attorney basically is pretty much the same. Okay? If you don't have a healthcare power of attorney form, they will look to your spouse. Okay? you can designate someone other than your spouse as your healthcare power of attorney, and then your spouse has no say. So it's who is first on this list. And typically what you will see is that you may want to designate your spouse. You may want to designate a sibling, okay? And basically most of the time they recommend leaving this physician thing blank, because not a lot of your primary care physicians do hospital care anymore. So they recommend leaving that blank. And you can see that what you can strike through or add to any of these, but most of it sort of mirrors, okay, the living will document, okay. Organ donation basically is in the power of attorney document. But what you will see is that these two documents, as I said, do not require an attorney. They just have to be notarized. And then you need to have copies of them available. Now, can someone revoke their living will?
Yeah.
When?
Anytime.
Anytime.
As long as they're sound
Even if you're not a seven month?
No. You have to be quote-unquote competent, okay? Or you look to your healthcare power of attorney and say, I changed my mind, okay? But what you will see is that if you do change your mind, you definitely need to get those documents pulled.
Now, do those go, are those held from like your senior doctor?
Basically, CMC keeps them. Don't they keep them on file forever and ever, amen, until you replace the documents?
I'm talking about like if you go in and have surgery, or is your living will still in effect if you're having surgery done?
It is, unless you designate that period that you don't want that, if you were to stop breathing, well, of course you're going to stop breathing because the machine's breathing for you, but if your heart beats, you can say my living will is in effect or it is not in effect. You can revoke at any time and then reinstate. Now, the thing that you have to remember is that, yeah, I may have a living will, and I don't want to be resuscitated, but what do we as nurses have to do when this person comes into the hospital?
Make sure you know what they got.
Make sure that's what they want.
Okay, but what else do we
You have
want
to
to
have that
file?
form and have the physician sign it.
Yes, there has to be a written physician order on the chart as a DNR or do not resuscitate. Even though this person may have a living will, and they may have let their wishes known, in the hospital, we have to have a DNR order written, okay, to make sure that legally the hospital is covered. Now, let's talk about when you go to, say, for example, a nursing home or hospice care. They've been a DNR in the hospital. Does that automatically make them a DNR on the ride to the nursing home? No. What you will see is that the physician will have to fill out what we call a MOST, M-O-S-T form. Okay? It's medical order something, I don't know. It's sort of goldenrod in color. Okay? So that EMS has to have that form on that ride to the nursing home or to hospice so that if that person does arrest, they do not have to initiate CPR. They are legally held liable for not starting CPR if they don't have that form. So basically what you're going to see is that, say for example, someone is in hospice care and a family member panics and calls EMS. If they don't have that form available, then what you're going to see is that EMS will initiate CPR. Typically what you need to tell patients is if they're in hospice care, they call the hospice nurse. They don't call 911. Okay? Questions about advanced directives? Always, always, always know what your patient's code status is. Okay?
This one that you just talked about, is that just the most form? Is that just for EMS?
Well, it's basically for anything outside of the hospital, and you will see it for nursing homes as well, or assisted living facilities, or anything non-hospital. A lot of times what you will find is that those forms in hospital are standard. You may have a standard form that is for the nursing home, but most of the time they use the MOST form outside of the hospital situation. But that form, I don't care if it's Rowan or Northeast, the DNR form is very similar because it is a legal document. Okay? Any questions on advanced directives? All right. What I want you to do now, talk about today is managing stress and time. Very appropriate. Well, appropriate. Stress, you know what stress is. It's the non-specific reaction that people have to threatening demands from the environment. Stressors can be positive or negative. Positive stressors, basically what I will tell you is that those are the ones that incentivize you to do something that you may not have done unless there was some kind of threat, i.e. I gave that test and some of you on the priority setting, some of you got one of them right. The average was 40. But I'll tell you, on that priority setting test, you guys did a wonderful job, and you got the majority of those questions right. So I think a little stress basically motivated you to look a little deeper and to figure out what was going on there. Negative stressors, well, basically, those are the ones that sort of bring you down, that keep you from doing what you need to do, or to make sure that, it's just sort of like, I don't know, a lot of you are not of the age to know what Little Abner was. But there used to be this little guy in there called Joe Blissophic that used to have this black cloud that sort of stayed over him. And so no matter where he walked, this little black cloud was over him. And he was one of the people that everything that was bad that was going to happen happened to Joe. So what you're going to see is that a lot of times negative stressors build up and up and up and really decrease our ability to cope. Stress, basically, there has to be an ability to handle that stress, and there sort of needs to be a balance. So what we see in the hospital is that a lot of times whenever you have patients that have acute illnesses, it basically decreases their coping ability, and you will see that often they will respond to stressful situations by inappropriate or coping mechanisms that are not helpful or helpful. Okay? What kind of responses do you see sometimes in the hospital to stress from your patients? Anger, depression, depression, peeing incontinent, is that what you said?
Simply
Well, stress incontinence, yeah. Fatigue, okay. What usually happens to nurses in stressful situations? What kind of, you get the same thing. You get anger, you get gossiping, you get backbiting, you get nicotine. Well, that's sort of illegal anymore, especially since someone caught the bush on fire at the Wells Fargo over at CMC Northeast. Someone that basically was out taking their nicotine break and did not put their cigarette out and caught the bush on fire. So there was this major email that went throughout CMC. Do not smoke anywhere. Especially do not act like Moses. With the burning bush. Organizational stress. What do I mean by organizational stress? You have to have this done by this time. Miss Graham and her demands for those immunizations and those flu shots, making sure that we follow the rules so that we can keep these clinical spaces. By the way, Miss Graham is having a knee procedure this morning, so you got to think about her. What about interpersonal stress? Your wife, yeah. Your wife, your spouse, your significant others. What about your kids? All the demands, okay? Remember I talked a little bit about that superwoman or superman phenomena where we try to do it all and we try to do it the best that we can, okay? A lot of times we put stress on ourselves because we want things to be the best that they can be whenever we turn things in, okay? What about in the ICU? The constant beeps, the noises. Typically what you will find is that nurses tend to tune them out after you've been in there a while. Okay, any of you have ever worked in retail where they have that music? Okay, how many times do you hear that music after you've been in that store for a while? You don't listen, you don't hear it anymore. Unless they do something by the Beatles and then you're going, oh God, why did they do that? Speaking of which, the first time I heard AC/DC and music, I liked to agree. Tight quarters, not enough room to do work. Okay, how many of you worked in the ICUs as care partners over at CMC Northeast? Okay, what kind of toilets do they have over there? They're under the sink. You open the cabinet door and the toilet is it rolls out, and that's where the toilet is. So everything that you need to do, if the patient needs to get up, you open the cabinet door and they sit on the pot, and then you flush and then close the cabinet door. Tight space, okay? Very inventive with the way they did it, but it's a small toilet. So you have to make sure that you hit the spot, so to speak, especially if you're emptying a bed pan or whatever. What about your manager's behavior?
Yeah, that counts.
What kind of things?
Some of them are dicks.
Woo! Some of them are. I need to show you something on the internet. It's not appropriate and not sufficient for public viewing. Basically what you will see, and we'll talk more about this on Friday when we talk about some of the managerial behaviors, authoritarian behavior, meaning like the Army, okay? Or the punitive behavior, they impose punishment. Sometimes for doing good things, but you don't follow the rules and you get punished for it. Organizational norms, like having to do more with less. Those staffing grids are basically one of the cost-saving containment measures that a lot of hospitals have gone to. But if you think about it, what you are trying to do is a lot more with less people, because what those staffing grids do is they look at numbers of patients. They do not look at acuity. Okay? And what you're going to see is that a lot of times you can take care of 30 patients with no problem if they're walkie-talkies. But walkie-talkies are not in the hospital anymore. Okay? So what you're going to see is a higher acuity of those patients, and it's going to extremely increase your stress. Okay, so interpersonal factors. Well, doctors, administration, and multiple roles that the nurses has to play. Remember, I talked to you about the nurse as the coordinator of care. Okay, so that we, as the nurse, are sort of the liaison between the patient and the doctor, the patient and the physical therapist and the doctor, the patient, the therapist, and the family and the patient. You know, it gets to be so that you're running interference or trying to coordinate the care of this patient, and it can cause a lot of stress, especially with some of these very, very complicated patients that we're seeing now. Now, one of the things that you'll see that can cause stress are life changes. And one of the things that I've got for you is it's a stress inventory. So I'll let you take a few minutes and figure out what your stress is, okay? Some of these signs and symptoms go up. Anxiety, phobias, persistent state of fear. Okay, the higher the stress level, the higher the likelihood that you're going to see that. Depression. Just think of little Joe Blissett with everything that keeps happening to him. Depression is going to be an issue that you might see with your patients or yourself as well. Perfectionism. Okay? People that strive to be perfect tend to have more stress in their life than those just people that do the Let It Go song. And after I've heard it 142,000 times, I'm about ready to let it go too. Physical illnesses, stress-related illnesses. What are some of the stress-related illnesses that you see? High blood pressure. Migraines or cluster headaches. Upset stomach, maybe like help with heartburn or hiatal hernia. It will worsen those symptoms. Dysrhythmias, especially if you drink a lot of storage along with that.
It's not proven in cancer.
Cancer. It's actually, I think there's a very high correlation between the studies that I've seen. Diabetes, obesity, I think, definitely with a lot of people overeating or is a coping mechanism that contributes to obesity.
Sedentary.
The sedentary lifestyle. Okay. Coping mechanisms that are perhaps not as effective. They may be very effective
but they're not very conducive to health states. Alcohol, okay? We see a high incidence of alcohol used as a coping mechanism. It's okay to cope once in a while, but let's not cope every day, okay? Mood-altering substances, that would becoming a workaholic, okay? If you work all the time to strive to be perfect, basically what that's going to see is that it increases your risk for burnout. Increased absenteeism and turnover is one of the things that you will see with high stressful situations. A lot of times what you will find, and I'll give you just a clue, guys, if you are looking for a job, if they've got 6 positions open, take one with very much a grain of salt. Because unless it's a brand new unit, something is going on that they've got 6 positions open that the working conditions may not be the best in the world. Okay? All right, so how do we handle stress? Nicotine, caffeine, sleep, crying. Exercise is actually one of the better ways to handle stress.
Sexual intercourse.
There you go. But you have to have a willing partner. Or a good right All Managing stress. Okay, one of the things that you definitely want to do is recognize what your stressors are and try to control them. If you are in a situation that's totally increasing your stress, you need to deal with it. Ignoring it so that hoping that it will go away is probably not the best way to deal with that. You need to make sure that if it's in your work life, perhaps time management strategies may be one of the things that would help you with managing your stress. Positive self-talk and relaxation methods, that little mantra that Ms. Beaver does. I love myself, I love myself, I love myself. Basically is a positive self-talk. The thing is that a lot of people don't recognize that, there is, it's sort of like Yoda says, there is no try, there is do or do not. Okay, so basically what you can tell yourself is I can do this, not I will try. Basically, if you positive self-talk, a lot of times what you will find is that it will increase your ability to do a job or to come up with something. Now that means that you have to be prepared, because just sort of doing this, okay, doesn't work. All right, organizational methods. Hopefully what you're going to see is that that nurse manager can identify some of the stressors and try to reduce it or eliminate it. What are some of the stressors that you've seen in your work world, whether it be in healthcare or at the 7-Eleven or wherever you've worked, that you recognize that there was a problem and talked to the manager about it and they were able to do something about it? Any of those things? Any ideas?
Well, at work, when we had citations, we would have to tear down the rooms. And they finally, because it was taking so much time for us to pick them apart and put them together, that they took the family waiting rooms that were in the ER and changed them into psych holding rooms, so they don't have anything in those.
Yeah, and that would be a significant stressor, because you can imagine trying to tear that room down and then set it right back up for perhaps someone that comes in with a mini trauma, so to speak, would be a major problem. Okay. What else? Any other ideas?
There's a lot of gas stations that are robbed that actually put plexiglass up over the cash registers so they're not in contact with
Yep.
customers.
Yep. My daughter, one time we were in one of those little gas stations and she saw the measurement bar on the door, you know, so that they could tell how tall the robber was. She was wondering if that was there so that you could measure yourself to see if you're tall enough to go in the gas station. No, not quite. Not quite what those are for. Communication definitely is one of the keys that you're going to see whenever you are trying to help manage stress. And what I would tell you guys is to find someone that you can talk to, whether it be your friend, whether it be your spouse, whether it be someone, because sometimes just sharing information and just being able to let it out is one of the things that you're going to see that will help major decrease your stress. And if you've got a good friend that you can do that with, it saves you a whole lot of money than going to a therapist. Okay? All right, so let's talk about time and time management. Well, we can't control the amount of time available. We can only control how we use it. Once it's passed, it's gone and cannot be replaced. And I don't care how much you wish for it. There are only 24 hours in a day, and all of us do require some sleep. Some of us more than others. Some of us less than others. But what you're going to see is that time management skills are one of those things that are going to be critical to your success. Organization and monitoring of your time can get you through a very, very rough day. One of the things that you're going to see is that preferences for doing things that you like to do will take priority over things you don't like to do. And sometimes what you will find is that those things you don't like to do may be the priorities for that patient. So you need to sort of figure out, you know, what's have to do, what's need to do, what's nice to do. So those are things that you can figure out. And you will need to prioritize the have to do's before the need to do's. The nice to do's are there if you have extra time. But unfortunately, what you're going to find is that most of the time, the have to do's and the need to do's take up the time that you need. Setting goals and priorities for your work schedule for your 8 or 12-hour shift is going to be one of those things that's very important. One of the things that will also help with time management is delegating. And we talked about delegating and what's appropriate to delegate and when you delegate. Minimizing paperwork. Yeah, right. There is no minimizing paperwork with computerized charting. Basically, what we hope to do with computerized charting eventually is to eliminate some of the redundancy of charting. That's one of the things that, unfortunately, what we found whenever we first went to Cerner at CMC Northeast is that there were 3 different places that you could chart, like blood sugars. And what happened is that we used to get dinged because we weren't charting blood sugars. Well, yeah, we were, but we were not charting them in the place they're auditing them. So, well, tell me where you're auditing them, and that's where I'll chart them instead of where we've been charting them.
So one of the things you'll find is that with computerized charting is that hopefully, eventually, some of that redundancy will be out and we can see linking between the things. So that point of care blood sugars that your care partner enters goes to your medication record so that it's right there whenever you do your sliding scale insulin versus having to look 3 different places to try to find where that is. Using schedules that avoid interruptions. Have these people ever worked in a hospital? All right. Yeah, I don't think so. Basically, what you're going to see is that you can have the best laid plan whenever you get to this next semester and you've got 3 or 4 patients, either in your preceptorship or in your clinical rotation. But you know that if the needs of one patient come up as a priority at that time, it's going to screw up your whole system. What you're going to have to learn is to be flexible and be able to adapt. Sort of like the Marine Corps, adapt and overcome. So we want to make sure that whenever we come up with this perfect plan to manage our time, that we are able to do extra things that may interfere with that. Those of you that are care partners, how do you plan your time to do your job on your units? Okay, so what kind of things have to be done at that certain time? Blood sugars, blood pressures, EKGs maybe? Okay, so when do you do baths? After breakfast? I don't want a bath then. So what do?
You don't get it.
You're going to get one.
Do it now, or I may not have time later.
Yeah, and that may be, I take my bath at night. I have the right to say I don't want a bath at this time. Though it was really funny, after my child was born, they, of course, Elizabeth was born the 2nd of January when everybody and their brother was on vacation. And I think I was one of 4 people on the maternity unit. And they had pulled a flight nurse, one of the helicopter nurses, up to the maternity unit because they had to have someone else up there. So she was my nurse. And she comes in and said, "You don't want a bath, do you?" I said, "Not from you." So it was like, okay. But yeah, I want a bath. I've just been through this C-section and I feel awful, so to speak. But not from her. I called my unit and they did a neuro bath. And basically everyone took a limb and went in. So, anyway. But what you're going to have to do is be flexible. What are some of your big time wasters? Either school or work.
Paperwork.
Paperwork. You want to try grading?
I think they don't know
I would have never been a teacher.
What are some of the time wasters? Forgetting what you're doing, TV. How many of you have let me check Facebook for just a minute, and 3 hours later, oh shoot, I better get started. Naps.
Those are required.
Those are required. Those are not optional.
But when you wake up,
That's what the alarm on your phone is for.
you can snooze a minute if you
No. You put it across the room.
No, that's the first thing you grab it and break it.
I don't hear my alarm get up. I don't realize it's on.
Yeah,
That's why mine sounds like the fire alarm.
I got that something else.
What else?
time waster?
Doing dishes.
Yeah, doing dishes.
Standing in line.
See, I don't mind doing dishes. It's emptying the dishwasher that's
I don't mind that.
My husband, who irons?
We do. We do. Our house.
I only iron when I
You know where to take
All right, so there are a lot of time wasters out there. What's one of the biggest ones at work? Patients talking to you. Yeah, that's a needed thing, but for a long periods of time, sometimes it's sort of like I've developed signals with other fellow nurses that, you know, I'm going in room so-and-so. She likes to talk a lot. Can you call me or page me if I'm not out in 10 minutes? All right, any of you ever done that? It works. Okay, sometimes you know, oh yeah, someone else needs me. I'll be back in a little bit. So sometimes you need saving like that. Sometimes they're coworkers that you need saving from as well. Yes. Basically, one of the things you want to look at is the big picture. What are some of your desired outcomes? You need to separate them into optimal versus reasonable. And a lot of times what you're going to see is that those reasonable outcomes are what we are going to be faced with, especially if the work schedule and flow is a little bit more than we can do with the limited resources that we've got. Now, one of the things that will help you with some of your time management is you need to develop your own style of keeping records on your assigned patients. A lot of times what you will find if you will look at the nurses that you're working with, especially in this next semester, is they've come up with their own form that they've developed that helps them keep everything straight. Where they may jot a few things down and then go document and cross it off their list. Or they come up with a medication schedule, like 9 o'clock's here, so that they've got them charted out so that they can come up with, so they don't miss something. Okay? Those medication task lists that you're going to see over at CMC Northeast, there's a good way that you can do checkoffs to make sure that you've gotten the meds done. Paper Mars are not as convenient because you can't sort of carry those with you. But you need to come up with your own way. And if you're into lists and checkoffs, great. That's a good way to do it. It makes me feel accomplished when I'm able to cross something out that I've got it done. Sometimes I do things and then put them on the list so I can cross them off. Any of you ever done that? All right. The rhythm model, not the rhythm method. Okay. But rhythm model is using that PQRST, prioritize, question, recheck, self-reliance, and treat, is a way that you can look at. Look at with your assignment. Prioritize the things that have to be done. Question, did I get my priorities straight? Recheck, meaning maybe go back and see after you've done a few of those items on your list to see if your priorities have changed. Because that's one of the things that you will find. Priorities will change multiple times during the day. And that's why you as the RN have to learn how to set your priorities. Because you need to do those rechecks. Because if you're going from what your priorities were at 7:30 and your patient conditions have changed by 3 o'clock, then you're going to be in a world of hurt. Okay? Self-reliance and treat, basically, what can I do by myself? What do I need to delegate? Treat what your priorities are. Now, if you look at where nursing time is spent, only about 35% is spent direct care. That goes up to 50% if you have an all-RN staff, like in your ICUs. Okay? 20% is spent doing documentation. I think probably that would go up with computerized documentation. Remainder of time is spent transporting patients, performing administrative duties, and providing hotel services, i.e. getting something to eat, making sure that they've got shampoo or towels or whatever. Basically, what you need to recognize is, does it take that RN to do any of these things? No. These are things that can be delegated. And what I would tell you is that if you can delegate those to someone else, definitely do it, because it will greatly increase the amount of time that you can spend in direct care. Okay? This is basically a nursing unit. Now, clinics, physicians' offices, OR, PACU will all differ. Now, when you're talking about time management, basically think of it as a priority setting, because that's what's going to allow you to come up with what you need to do. What are the things that I have to do to make the optimal or reasonable outcome? All right. What we want to do is work smarter, not harder. What are some of the ways that you can do that? Delegate, definitely. Cluster care for patients that you can cluster the care for. I mean, giving 8 o'clock to 9 o'clock at the same time eliminates going into the, if those meds can be given at the same time, is a way that you prevent having to go to that patient twice. What are some other things? Have your supplies with you. Organize, okay? One of the things that I usually don't do fundamental students, because I have to keep my arms like this. And my chiropractor says that that's a bad thing for my shoulders and neck. Because I want to just say, let me do it. All right. Making sure you've got your equipment that you need. One of the things that you'll learn as a nurse, you keep alcohol in your pocket, you keep extra pens, you keep flushes, okay, so that you look like Megatron when you go through a transformer, so to speak. But one of the things you need to remember to do at the end of the day is take all that stuff out of your pockets, because you don't want to be taking it home. One of the other things that you're going to do is gather everything you need for that job, but you don't want to overload that person's room. Okay, one of the things that's we used to really do is that if someone had a dressing change, basically a whole box of sponges would go in, a whole box of Acrylics would go in, everything would go in that room, and then at the end when the patient's discharged, it went back on the cart. Well, in today's infection control situations, we can't do that anymore. So what you may need to do is to cover your shift. What am I going to need to do if I'm doing this dressing change twice in this shift? Put enough in for those 2 dressing changes and not overstock those rooms, because you don't want to be wasteful. Okay, but you need to make sure you've got the materials for the job. If you're unsure about what you need, definitely you're going to make sure that you ask someone, look at the policy. What do I need to do this specific skill? Making sure that someone that has more knowledge than you, and hopefully that's your preceptor or someone on your unit, has done that before. It's one of the things that used to drive me crazy is that when I get pulled to another unit, you never knew where anything was, or you didn't know what types of dressings that these particular physicians preferred. Okay. At the end of your shift, one of the things that you want to do is, did you achieve those outcomes that you set up for yourself? If not, why? Were there staffing problems or patient crises? Okay, if you've got one patient CTD, okay, circling the drain, your other patients basically are not going to get as much care as they need unless you delegate or assign someone else. Keep an eye on my patients while I'm tied up in here. Because one of the things you don't want is that patient that's circling the drain to get all the care, but someone over here also begin that slow swirl and it not be recognized. Okay? Did you achieve realistic outcomes? If not, why? Well, I couldn't care for this patient because they were gone to x-ray for 3.5 hours. And I wasn't unable to do my assessment or follow-up assessment. Because hopefully you were able to do the assessment before they went downstairs. What did you learn for future shifts? And that's one of the things that you will learn as you go through about your time management skills, is that you need to look at, what did I get accomplished today? What do I need to do differently tomorrow that might help me? And you guys, you know just as well as I do, that first day is always rough. That second day usually is a little bit better because you know those patients and you know the routines a little bit better. So what you're going to see is that when you're working 2 or 3 days in a row, you're going to get a better idea of how to do your routines. Okay? Questions about stress or time management? All right, let's take a 10-minute break to rest. Continuing competence is something that you guys are going to have to know about. Because once you're licensed, okay, NCLEX, RN, is the establishment of minimal competence, okay? So that means that you're safe to practice as a licensed nurse. Continued competence by the North Carolina Board of Nursing definition is the ongoing acquisition and application of knowledge and the decision-making, psychomotor, and interpersonal skills expected of the licensed nurse, resulting in nursing care that contributes to the health and welfare of clients served. In other words, once you get that license, you have to continually update your knowledge. One of the things that you will find is that in healthcare, pretty much everything changes about every 5 years. What they've said is that by the year 2020, the total amount of knowledge that we have in caring for these people will double every 10 years. So think of all we've tried to cram in your head now. All right, in 6 years, you're going to have to cram double that in your head. All right. Basically, with continued competence, what the board says is that the board is responsible for protection of the public through the regulation of safe, effective nursing care. That is the mission of the North Carolina Board of Nursing. What you will see is that we talked about that initial competence. Because nursing practice changes rapidly, initial knowledge can become quickly obsolete.
when I first started nursing, if you were having a laminectomy, a lumbar laminectomy for a herniated disc, you came into the hospital the day before. We showed you what the OR looked like. We showed you what the recovery room looked like. And then we taught you how to do all this stuff. And then you were in the hospital for 5 to 7 days. And then we sent you on your merry way. Well, lumbar laminectomies, if they're done in the hospital now, a lot of them are done as outpatient surgery, which scares me to death. Basically, would be 1 day, same day entry, and then they're discharged within 24 hours. They only keep the anterior cervical fusions, where they go through the neck and fuse that for 2 or 3 days max. We used to keep them in the ICU that long. So what you will see is that what you learn here in school, you probably, with the skills like catheterizations and IV pumps and those types of things, you will not use in probably 10 years. It will be totally different. So you're going to have to learn all sorts of different things. The Board of Nursing is committed to ensuring that nurses maintain and develop their skills and competence. Because what they don't want you to do is to think that, well, I'm out of school, I don't have to do anything anymore. Wrong. What you will see is that every 2 years you will have to renew that license that you get. Positive thoughts. That license that you get on the first try. Okay, so what you will see is that every 2 years, when you go, that license goes up for renewal, you will have to prove to them that you've maintained your competence. And one of the ways that they do that is through what they call reflective practice. It's a process for the assessment of your own practice and to identify and seek learning opportunities to promote continued competence. In other words, what they want you to do is to help identify goals and progress from that novice, new graduate nurse to an expert. And it may be in one particular area, for example, med-surg or for ICU. Okay? I know a lot of you have said that you want to do labor and delivery. Well, what you will find is that they don't take new grads directly into labor and delivery. Typically what they will do is Jason is going to have to go to med-surg, and then he might have to go to mother-baby for a while, and then he goes to labor and delivery. I know he's one that's told me that no way, no how. But what you will find is that each time you move from like one specialty area to another, you sort of go back to that novice. You may be an experienced novice, but you go back and learn a whole new skill set, okay? Till eventually you become that expert nurse in that area, and you're the one that's precepting all the new grads, okay? What they like you to use is the ABCD method. Assess your practice, base it on standards, and those standards may be specialty organization standards like the Med-Surg Nurses Association or my Neuroscience Nurses Association or AACN, the American Association of Critical Care Nursing. So there are standards of care that we provide for these patients. Collect feedback, and that feedback may be from your manager. It may be from your co-workers. What did you find helpful in learning how to take care of these patients? Okay? How many of you are interested in ICU? Okay? what are some of the things that once you get out and get your license that you're going to have to do for continuing education to work in that ICU? ACLS, American, the Advanced Cardiac Life Support, PALS, Pediatric Advanced Life Support. Those of you that work trauma, there is a trauma life support. TLS is fun. It's very intense, 3 days, but it's fun. What other things are you going to have to learn to do? Continuing education, okay? Ms. Rommel is certified as a critical care nurse. One of the things that you will see is that to maintain that certification, she has to have a specific number of critical care hours worked, and she has to have a specific number of continuing education units. I just renewed my medical surgical nursing certification. I had to have 150 continuing education hours to renew that. So it's a significant amount of certification hours that you have to do. My certified nurse educator, I want to say I have to have 50 hours for that. Now, the North Carolina Board of Nursing, for you as a registered nurse, you have to do 30 hours over 2 years, or these are some of your options. You can have a national certification or recertification by a national credentialing body recognized by the board. Well, I just told you that I had to have 150 hours for this med-surg. So that definitely would satisfy the Board of Nursing. Most people do this 30 contact hours of continuing education. It's over 2 years, though, for that licensure. And what you will find is that it can't be that I go to Amanda and say, Amanda, I need to know about how to work this pump. And Amanda tells me, and then she signs my certificate. No, that doesn't work. It has to be a system. You know, a lot of times it can be like through your hospital or continuing education companies, or a lot of the stuff that I use are free resources on the web. Medscape.com will be one of your best friends because they offer free continuing education. Continuing education credits can be very expensive. One-day workshops, a lot of times, will cost anywhere from $150 to $300. A conference registration fee that I want to go to in January in Las Vegas, this doesn't include getting there. The registration fee is $500. Don't think I'm going.
How many credit hours do you get?
Well, for this particular conference is 40 hours, okay, because it's a 5-day conference. And that would wipe out a lot of my requirements in one fell swoop. But $500 registration plus plane fare plus gambling money plus the shows and whatever else would be a little expensive. So,
Suitcases for all of us.
and suitcases for all of you. Yes. And if I hit on the craps table, I'll retire. That's why there's a lottery backup. Yeah. But one of the things that you'll see is that there are other things. There are a couple of RN CEUs, and then the American Nurses Association, and there's another one that's done by like nursing magazines. A lot of those have CEUs associated with them. You know, a lot of the articles that I put that have the nursing made insanely easy have CEU credits that have the questions at the end. Those are basically fee for service. A couple of the agencies, it's just like $29.95 for a year's subscription. It's like buying a magazine. Only you're able to get up to 30 continuing education hours for that $29.95. Or you can get 3. It just depends on how motivated you are. And usually if you look at my continuing education record, I get very motivated when I get bored. And I go on and do things like that. But what I would tell you is if you are a CHS employee, they will pay for a lot of your continuing education because of the educational credit. And if you don't use that money to go back to school, then please spend it for continuing education, because you're crazy if you don't. Because I don't know what it is now, but it used to be $1,500 a year for an RN after you'd been there for, 2 or 3 years or so? And if you let that $1,500 sit, you're throwing away money. Get them to pay for your continuing ed. Okay? They will not pay for your certification exams, but unless you work out a deal with your nurse manager. But it's very, very helpful that $1,500, it would have paid for my $500 registration fee for this thing in Las Vegas. And then I would be responsible for the food and drink and gambling and whatever else. Don't try to put your gambling debts on your reimbursement account. Okay? The other thing that you will see is that there's other things that you will this is probably what a lot of you will use. 15 contact hours of continued education and 640 hours of active practice. If you're going back for your BSN or going back for your master's, those will count as your continuing education credits. So you don't have to have those 30 hours plus go to school. Okay? So that if you have at least 15 contact hours in 2 years, which will probably be about, 4 courses, 5 courses? And then you work at least part-time, that will knock out your continuing education credit. Questions about continued competence? Okay, what I will tell you guys is that it's sort of a interesting way that they do this. When you're licensed, you get that document that says you're a licensed RN. What you will find is that some of you will be licensed for 1 year, and then it's renewed in your birthday month. Some of you will be licensed for 18 months. Okay? So what they try to do is stagger the renewals so that they're not always due. It's always due the last day of the month of your birthday. So it's one of those things that you have to remember. And unfortunately, you don't get this nice license that you carry in your purse anymore. It looked like a credit card. It's basically now, look it up online. So what you can always do is log in to the Board of Nursing and see when your license expires. Now, it is your responsibility to make sure that that license is renewed every 2 years, because there is no grace period. There is no grace. Basically, what happens is that if I forget and don't turn in my paperwork until late, and my license is not renewed by the 28th day of February because my birthday is in February, then I cannot work as a nurse March the 1st. If I do, that's practicing nursing without a license. And not only can I be brought before the board, but my supervisor can be brought before the board for hiring a person that does not have a nursing license. And our names go in this lovely little bulletin for everyone in the world to see. Okay? So it's one of those things, there is no grace. You have to have it done before the end of that month. Now, how do they know that you've done this? Well, what happens is that every year they pick a selection of people, a percentage of people that says, you're the one, send me all your documents. And typically what people do is scramble to fill out all these forms and come up with their continuing education stuff and send it in to the board. So what you will find is that it's a good practice to keep those in one file by year so that you can come up with them. Okay? Because you don't want to have to go to this agency that you went to a workshop, one-day workshop, and say, I need another certificate. They say, well, send me $15 and I'll be glad to provide you with another one. So it can be a little bit of a racket. So just keep up with your certificates in case you do get audited. And they do audit about 10% of the people that have to have license renewal every month. So it's easier to keep it together than it is to make sure, that that you're scrambling around, because you cannot work without that license. Questions about that?
So when it's time to renew, do you just send in like a list or transcript of what you've done so they'll know?
Unless you're audited, you don't have to send it in. You basically electronically sign an affidavit that says I have completed the continuing competence requirements for relicensure, like you do on your CNA. And whenever you send that application and your money back in, you might be randomly selected to do the audit. Okay? If you are, then you have a period of time to get those documents in, and if you don't get them in within that time period, they will not reissue your license. Okay? All right, couple of other things while we're waiting on our guest speaker.